in this proof of concept study, we looked at patients who were either randomized to placebo or to the active agent. And in the active agent, patients will be going on 25 milligrams, and it could be increased to 50 or 75 milligrams based on tolerability and patient efficacy. In looking in this way, we use the SAPS-PD, a validated scale, to identify the frequency and the severity of Parkinson's psychosis, both hallucinations and delusions. Patients who had significant symptoms of Parkinson's psychosis with frequency and severity of hallucinations and or delusions were enrolled in the trial, and they were followed over this 6-week trial during which the medication could be increased. And we compared the SAPS-PD at week 6 to baseline to identify if there was a signal of efficacy and to also identify any safety or tolerability issues. So in this exploratory study, we're able to show that this separated from placebo, but not enough to have statistical significance. So the pre-specified primary endpoint was not significant. But we could see an improvement on the SAPS-PD beginning as early as week 1 and maintaining out to week 6 in the total SAPS-PD, more so with patients who had cognitive impairment and lower mini-mental scores. We saw perhaps a larger magnitude effect, again, not significant against placebo. Most importantly, though, there was no worsening of the UPDRS, suggesting that this lack of affinity for dopamine receptors translates to not worsening motor symptoms and becoming only the 4th antipsychotic that we're aware of that can have efficacy against psychosis symptoms without worsening motor Parkinsonism. And because of this signal on efficacy and no effect on motor symptoms, it seems to be a medication that we'd want to further explore for our patients with Parkinson's disease psychosis. Perhaps most interestingly in this proof of concept trial was that while we didn't reach statistical significance in the primary endpoint, we identified that 25% of enrolled patients on SEP-363856 had a complete response, 0% on placebo. And the best comparison perhaps is that with pimavanserin that's approved for Parkinson's psychosis, about a 14% of patients had a complete response. So this gives hope that either in all patients or certain patients who may be more driven by this TAR1 mechanism, this may be a very helpful antipsychotic to improve psychosis symptoms without worsening motor Parkinson's. So currently, we're evaluating how to proceed in Parkinson's psychosis. Clinical trials can be difficult, both to enroll patients who have significant symptoms that need to be treated, but also those who might have be put on placebo for 6 weeks. And we want to think about non-pharmacological lead-ins, perhaps, to try to manage the placebo response. The placebo responses can be quite robust in these types of trials, both due to Parkinson's disease and psychosis types of trials. So I think we're trying to identify the right patient population, to identify the right dose, and to identify how to control the placebo response and how to maintain the integrity of the primary endpoint, and to use the validated SAPS-PD scale, I would imagine. So this is all under discussion now, and hopefully this will proceed in the near future to provide another option to be explored for our patients who continue to live with Parkinson's psychosis.